So another neurological syndrome is meningeal carcinomatosis. This happens most commonly in patients with breast cancer, but lung cancer is also common, and melanoma is another cause. So if one does multiple spinal taps, CSF will become positive in up to 90% of cases. And if there are issues in terms of being able to make a cytological diagnosis, then MRI can be quite helpful. It's of interest to note that CT scanning is really of no use in this setting. And the symptoms from meningeal carcinomatosis can be quite broad and vague. The patients may complain of headache, difficulty walking, nausea, or vomiting, and they may have multiple neurological signs and symptoms. So, for example, double vision, facial numbness, or even visual loss. And spinal symptoms may include paresthesia, back pain, and bladder and bowel dysfunction. So one looks for multiple neurological signs that accompany these diverse symptoms. So if the neurology basically doesn't fit with a single or may perhaps two different lesions, then it's something that you need to think about. Metastatic disease to base of skull is also a difficult diagnosis at times. One looks particularly for dysfunction of the cranial nerves, particularly the lower cranial nerves. And for example, involvement of the hypoglossal nerve indicates disease around the hypoglossal canal, and jugular foramina involvement involves the lower nerves 9, 10 and 11. Once again, the diagnosis is really made on MRI, and CT scan is not really appropriate, and the treatment is with radiotherapy. Fractured ribs, once again relatively common in breast and prostate cancer. They may not cause significant pain, but if there is a true fracture, they can cause transient and severe pain. The pain can be made worse by deep breathing, cough, sneezing and laughing. Sometimes it can be difficult to diagnose on a background of other chest pain with normal rib x-rays. And so if that were the case, then one would probably think of doing a bone scan to see if you could elucidate the cause a little bit more clearly. Once again, the treatment for fractured ribs is basically radiotherapy treatment, localized radiotherapy, and that can be given as a single fraction usually. Soft tissue pain is another area. Soft tissue pain is not as common as bone pain, but certainly can cause significant problems with pain. So one has infiltration of local tissue, and often it's in association with bone pain, and so you can get periosteal and fascial involvement. And both the fascia and the periosteum, of course, are richly supplied with nerves and hence significant issues with pain. One can get compression and infiltration of nerves and blood vessels as well. Infiltration of skin and mucous membranes can cause local pain, and if, of course, there's ulceration, then you can get local infection as well, and that's only going to cause more inflammation and exacerbate the patient's pain. So nerve pain is quite common, and the issue here is that it can sometimes be very difficult to treat with normal sorts of analgesics. So and the classical issue with nerve pain is gained from the history. So a patient may have lancinating pain or burning pain, but it's important to remember that sometimes the pain is described just like somatic pain in that it can be a dull, aching, constant type of pain. If the patient has significant issues, there may be sensory loss associated with the pain, so the patient might have dysesthesia and hyperesthesia as well. I guess the classical areas of disease involvement can be the brachial and lumbosacral plexus, and this can produce significant pain, sensory loss, and motor loss as well. So just looking at brachial plexopathy, one thinks of particularly lung cancer. Pancoast tumours are quite unusual, but often will present with signs and symptoms of brachial plexopathy. The other classic cause, of course, is breast cancer with metastatic spread to axilla and infraclavicular and supraclavicular lymph nodes. If the patient has had previous radiation treatment, one needs to consider the possibility of radiation-induced fibrosis, but you would really like to look very carefully and scan the area very carefully to exclude any local recurrence of disease. If it is recurrent disease, it's usually associated with more significant pain. The pain will come back probably earlier. If you're thinking about radiation-induced fibrosis, you may be talking about 18 months to 2 years after treatment, and the patient may also have sympathetic nerve involvement and hence a Horner's syndrome. Lumbosacral plexopathy can be associated with a number of causes. You can have retroperitoneal disease, so lymphadenopathy from any cause, or possibly a retroperitoneal sarcoma. If you have renal carcinomas which recur in the renal bed, and malignant psoas syndrome, so in tracking down the psoas muscle. Paravertebral disease of any cause which is in the right location, and then if one has basically more spinal associated disease such as epidural or intrathecal disease. So classically the patient will have back pain, and that back pain can radiate to the sides laterally and down into the buttocks and the legs, and it can be associated with sensory changes and weakness. So classically pain will start off slowly and insidiously, and then that will be followed by other symptoms and signs. It may be associated with other features that indicate local recurrence, such as leg edema, where you have disease that's involving the lymphatic system, and potentially hydronephrosis if the ureter on that side's involved, and then possibly DVT if there's significant enough compression of the pelvic structures and veins. So if you have a patient with a renal carcinoma and they get recurrent disease after nephrectomy, then the patient can complain of one-sided unilateral flank pain with L1, L2 nerve compression, and that pain will radiate down, or can radiate down, into the dermatomes of L1 and 2, which is in the inguinal region and upper thigh. The pain is usually made worse with activity, and if there is involvement of the psoas muscle, then pain can be an issue in terms of straightening the thigh, and weakness may be a problem in terms of flexion of the thigh. CT is the best way of looking at local recurrences involving the retroperitoneal area, including renal bed and iliopsoas region. So visceral pain is a different entity again. Visceral pain tends to be poorly localized, deep-seated aching pain, and referred to various cutaneous sites. About a third of patients with liver metastases complain of right upper quadrant pain. And liver pain in the cancer patient can present as an acute severe pain, and this is usually due to infarction or hemorrhage involving those metastases in the liver. There are different pains associated with hepatomegaly, such as just traction on the hepatic ligaments when the liver becomes very enlarged, associated with back strain, outward pressure on the rib cage, and even pinching of the parietal peritoneum.